So I'm very flattered to and privileged and honored to join you. I think there's a great opportunity with this Zoom platform to not just have lectures, but I'm exploring some very interesting technology using something similar to Google Glass, the old Google glasses, but much more advanced, that allows international workshops, surgical workshops, so that while surgery is happening locally in the US, it can be broadcast anywhere in the world, and discussions can occur during the procedures, whether it's for straightforward cases or for more complex cases. I think this is something that in the next few months or year, we'll have more information for everyone. And I think that will be a great opportunity to really do some meaningful workshops across the globe. So are we ready to, shall I share my screen now, Anil?
I think so. You can go ahead, sir.
Okay. There we go.
Put in.
Sir, this is perfect.
Okay, good. So I was asked to talk about the current perspective in the management of reflux. And the key message I want to leave everybody with, I'm going to put this message out even before we start the talk, is that I want everyone to think of reflux not as a black and white condition, not as a binary condition, but more like a spectrum. Because it is a spectrum. And that's the case I'm going to build throughout this talk. And I hope to leave you at the end with a message to be able to analyze your patients based on their own risk factors and then manage their reflux based on that spectrum of severity, so that you can offer your patients individualized treatment for their condition. In the 1950s, we began to realize the importance of reflux. In the 60s and 70s was the golden age for surgery for reflux, when all the new procedures were being introduced, whether they're the Cohens or the Ledbetter-Politanos or the Gilles Vernet, or the variety of procedures that were introduced for correction of reflux. And I'll tell you, in our fellowship in Toronto until the early 90s, our fellows were doing almost 150 reimplants. Contrast that with our current fellows who maybe do 10 reimplants in their fellowship. So you can see how the pendulum has shifted away from open surgery for that condition. But certainly the 60s and 70s were the golden era for open surgeries. Gene Smelly in about 1975 introduced the concept of continuous antibiotic prophylaxis for management of reflux. And that became the mainstay of conservative treatment throughout the 80s and close to 2000. In the late 90s, early 2000, people started moving away from continuing with continuous antibiotics for everyone past toilet training. In the 1990s, the concept of endoscopic correction of reflux became popular. And now you could probably argue that the majority of reflux is corrected endoscopically and a minority is corrected with open surgery or laparoscopically. In 2000 and the 2000s, the questioning of the value of continuous antibiotic prophylaxis became the prevalent thought process until 2011, when the American Academy of Pediatrics put out their guideline, their policy statement, indicating that there's no indication for diagnosing reflux since prophylactic antibiotics don't really make a difference. And then in 2022, currently, the big push is going to be that tailored management based on individual risk. And that's where we need to go with reflux today. When I was a fellow and an early consultant in my early years as a consultant, management of reflux was very straightforward. Every child had a VCUG after their first infection. And then they were all placed on prophylactic antibiotics. They had repeat VCUGs every 12 to 18 months. And if they had breakthrough infections or the reflux hadn't resolved after 4 or 5 years of follow-up, or they were non-compliant with antibiotic prophylaxis, or new scars developed during therapy, they underwent surgical correction for reflux. And as I said, our fellows used to operate on about 150 to 200 patients during their fellowship. This has all changed. And what prompted the change? What prompted the change was the realization that 50% of children with pyelonephritis do not have reflux. In North America, Europe, and many other countries in the world, the majority of parenchymal changes are developmental. They are not acquired infection-related scars. Of course, this is not going to be the case in your smaller centers in the less developed parts, away from the big medical centers, for example, in India or the Middle East. But that should be a goal. Preventing acquired renal injury should be a goal. The incidence of reflux-related renal failure has been stable over the past 50 years, regardless of how aggressive we've been with medical treatment and surgical interventions for reflux. In North America, 16% of the children that have renal failure have a diagnosis of reflux as the underlying cause for their renal failure. And that number has not changed in the past 50 years. So our goal as clinicians is preventing the morbidity of the infections and the acquired renal injury. Our goal is not correction of reflux. Our goal is a lot of children with low-grade grades 1, 2, and 3 reflux can live with reflux without any infections, and their kidneys are not impacted by that reflux at all. So I really want to repeat this point because that's a point that's missed on many clinicians. When they see reflux, they feel that their objective has to be to correct the reflux. This is not the situation in 2022. In 2022, living with reflux is okay as long as the child is not having recurrent infections. So we need to study the causes that result in recurrent infections in children, prevent or correct those, and if we fail and the child continues to have infections, then correcting reflux would be appropriate after we've done everything we can to prevent infections. And just to illustrate the point that infection is the key, this study from Sweden is very critical. They enrolled 303 children under 2 years of age after a febrile urinary tract infection. Some of these children did not have reflux, and most did. All of the children in the study underwent an ultrasound, a VCUG, and a DMSA scan within 3 months of their infection, and then a repeat DMSA 1 to 2 years later to evaluate the impact of the infection on the upper tracts, on the kidneys. 12% of the children in this study developed recurrent febrile infections. And the risk for these new febrile infections increased with the presence of reflux and the severity, the higher grades of reflux. But what's very interesting and telling in this study is this graph. If you look here, the children that did not have reflux and the children that had grade 1 reflux had identical renal scar incidence. And as the grade of reflux increased, the number of parenchymal changes and abnormalities on the DMSA increased exponentially. So the higher grades of reflux and was associated with a significant increase in DMSA abnormalities, which is something we need to pay attention to. So high grades of reflux and infection is not a good combination. Lower grades of reflux are not as harmful. The same message we delivered when we put together the American Urological Association reflux guidelines. And there we saw again that the greater number of prior infections was associated with more scarring. Very common sense message. So our job as clinicians is obviously correct and reduce the number of infections that these children have. So higher grades of reflux carry increased risk for recurrent infections and for new scar formation. In boys, most of the renal damage associated with reflux was congenital. In girls, it's more often acquired, and it's higher in children with higher grades of reflux. The second important factor that we need to talk about is this issue of who needs to be on continuous antibiotic prophylaxis, and are continuous antibiotic prophylaxis really beneficial in preventing infections in every child with reflux? And you're all familiar with this multitude of papers that came out in the last 20 years discussing the role of prophylactic antibiotics in children with reflux. And you could argue that these studies were not well designed and they were not powered sufficiently to answer the question, and many of them were not prospective. However, the issue was muddied enough. The question was sort of really put on the table: does reflux does children with reflux really benefit from being on prophylaxis? That the American Academy of Pediatrics, in their 2011 guidelines, put out this statement that the published literature doesn't support putting children on prophylactic antibiotics to prevent infections or renal scarring. And therefore, if antibiotic prophylaxis isn't really going to make a difference, why diagnose reflux in the first place after the first infection? So their recommendation was, after the first infection, get an ultrasound. If the ultrasound is normal, i.e., no evidence of parenchymal changes, no dilatation in the ureter, no bladder changes, then forget it. Don't get a VCUG, because it may be low-grade reflux, and there's no point in putting these children on prophylaxis because it makes no difference. However, this is, in my mind, a very short sight. This is the black and white concept of, reflux or no reflux. As I said, it's a spectrum. And to demonstrate the spectrum, the Swedish reflux trial was excellent at that. The Swedish reflux trial was a trial that was run across the country in 23 centers. It was a randomized control study. They observed, they divided children into 3 arms: an observation arm, an endoscopic treatment arm, and a prophylaxis arm. And I have to stop for a second and talk a little bit about the endoscopic treatment arm, because barely, just over 50% of the children that received endoscopic treatment had their reflux corrected. So 57% to be exact. The other 43% had continued with their reflux. So keep that in mind as you see the result of this study, because the endoscopic treatment did not select only the patients in whom reflux was corrected. It involved the patients that had endoscopic failures and successes. In my mind, the endoscopic failures are akin to the observation arm. They're not akin to the treated arm. So 203 children ages 1 to 2 were enrolled. The majority of them, 75% of them, were girls. They had at least grade 3 reflux, grade 3 and 4 reflux. So that's the higher risk group right there and then: younger and dilating reflux. They presented after a febrile UTI in the majority of cases, and they analyzed the febrile UTI as an intent to treat principle. There were 67 febrile recurrences in 42 girls and 8 in 7 boys. So obviously girls are at a higher risk, particularly in this higher grades of reflux in infants. Now, if we look carefully at the results, we see that the group that was on antibiotics had a 19% infection rate. The group that received endoscopic treatment had a 23% infection rate. And remember what I said here, that only 57% of that reflux was corrected. And then the group that was on surveillance had a 57% infection rate. So clearly, in this select high-risk population, antibiotics made a big difference. Infants 1 to 2 years of age with grades 3 to 4 reflux presenting after a febrile UTI. So as clinicians, we can't just blindly follow what a guideline that says it's all black and white. As clinicians, we need to be selective in who we treat with prophylaxis or who we correct reflux in. In order to sort out this issue of whether prophylactic antibiotics was helpful or not, the NIH in the United States funded the RIVUR trial. The RIVUR trial was funded to the tune of $6 million. It's the largest reflux trial in North America. It was a 2-year, multi-site, randomized, placebo-controlled. So half the children received trimethoprim, sulfamethoxazole, and the other half received something that looked and tasted exactly the same, but without antibiotics. 607 children ages 2 to 71 months were enrolled with all grades of reflux, 1 to 4, not 5. However, almost 90% of the children were in the lower grades of reflux. So now we've got two big criticisms in that trial before we even start looking at results. One is the choice of sulfamethoxazole trimethoprim, which in many communities across the world, E. coli is resistant to it. In some Middle Eastern countries, up to 60 to 80% of E. coli is resistant to trimethoprim sulfamethoxazole. And the second thing is the majority of children in the trial were the low-risk population, the grades 1, 2, and 3 refluxers. They were diagnosed, they had to have had either a febrile infection or a couple of episodes of cystitis to be enrolled in the study. And the study involved 19 clinical sites across the United States. Primary outcome, efficacy of trimethoprim sulfamethoxazole prophylaxis in preventing recurrences. And the secondary outcomes were renal scarring, treatment failure, and the emergence of antimicrobial resistance to trimethoprim sulfamethoxazole. And this is the summary of the results. You can see that the placebo group had a higher incidence of infections, 25% at the 2-year mark versus 13% for the antibiotic arm. And you can see that that difference widened as the study progressed towards the 2 years of the study. Now, how about renal scarring? Because that was one of the secondary outcomes. There was no difference whatsoever. And obviously that a big part of that is the fact that the children enrolled in the study were low-risk children, grades 1, 2, and 3 refluxers, and they had presented after their first known infection. So the incidence of scars overall were about 12% in the prophylaxis arm, 10% in the placebo arm. There was no difference in severe renal scarring, 4.8 versus 2.6. No difference in new renal scars from baseline, 8.2 versus 8.4. So antibiotics, prophylactic antibiotics in this population did not make a difference in who gets new parenchymal changes. There were some effect modifiers, and these are important as we build the case towards individualizing the treatment based on certain criteria that make a child more at risk. Children with grades 3 or 4 reflux at baseline were more likely to have recurrent infections compared to children with grade 1 or 2. Children that presented with febrile illness initially, sepsis, were at higher risk for second infections. Children with bladder and bowel dysfunction at baseline had higher infections during the study. There were too few boys to evaluate the effect of circumcision, but all 4 boys with a first recurrence were uncircumcised at baseline. So the RIVUR trial authors concluded that CAP reduced the risk of recurrent infections by 50%, 25 to 13, but not of renal scarring. And if you look at that number, is that really a meaningful reduction, absolute reduction of 12%, putting children on prophylactic antibiotics to reduce the number from 25 to 13? You could argue against. And their recommendation at the end of the paper in the New England Journal of Medicine was that our finding that antimicrobial prophylaxis was associated with reduced risk of recurrence may warrant reconsideration of the AAP recommendation. As a reminder, the AAP recommended not getting VCUGs after the first infection unless the ultrasound was abnormal. But if I was the AAP, how would these recommendations sit with me? Well, I would say prophylaxis didn't really reduce renal injury, renal scarring, or chronic kidney disease. And the reduction in infections, in my mind, is really very modest, that 12% reduction in infections. It means that you need to treat 8 patients for 1 to benefit. The likelihood of resistant organisms in the antibiotic arm in that study was higher. And frankly, if I was designing this study, I would have probably used nitrofurantoin, not sulfamethoxazole trimethoprim, because at least the resistant rates for nitrofurantoin in these children is going to be a lot less for E. coli. So on the one hand, we have the American Academy of Pediatrics saying prophylactic antibiotics are not beneficial. And on the other hand, the urology arm is saying prophylactic antibiotics is beneficial. And here we are with black and white, yes, no. And where we want to go with this in 2022 is we want to think of reflux as this spectrum. Because if our goal is preventing renal injury, then we need to look at the factors that cause the infection that cause the renal injury. And these factors include that the child was the reflux diagnosed after a febrile UTI, or was it diagnosed after a workup for prenatal hydrourethral nephrosis? And as an aside here, and we could discuss this later, we do not get VCUGs on children with prenatal hydronephrosis. We only obtain VCUGs in this population if they have a duplication anomaly, or if they have a dilated ureter, or if they have bladder abnormalities on the ultrasound. But routine VCUGs are no longer necessary in these children. Did the child present after multiple febrile UTIs? Obviously, these would have higher risk for renal injury. Do they have higher grades of reflux? At presentation, did they have renal scars or congenital parenchymal changes? What is the sex and race of the child? Obviously, white Caucasian girls are at much higher risk for renal injury than African-American girls. What is the circumcision status of the boys? And I'll show you some data that we produced demonstrating the impact of the foreskin in infection and how managing it reduces infection significantly. Infants are at higher risk for renal injury than children over 5 years of age. And the biggest factor in all of this is that determines recurrent infections, in my mind, is the presence of bladder and bowel dysfunction, constipation, urgency, frequency, lack of water intake, holding behavior, etc. So if we start thinking about reflux in light of all these factors, we can very clearly see that there's a spectrum. Reflux is not black and white. There is a group of patients that is at higher risk for infections. Let's spend a few minutes talking about bladder and bowel dysfunction. One of the last papers I participated on before I left, and this was a paper with Dr. Braga, he was one of the authors on it, back in the late 90s, we used to stop prophylactic antibiotics on all children with reflux that had finished toilet training. And then we followed these children prospectively, and we found that about 20% of them developed infections after we stopped their antibiotics. And if you look at the ones that we stopped antibiotics and they still had grade 1 and 2 reflux, they hardly had infections, but the ones that had grade 3s and 4 had obviously more infections. So again, you see the patterns that are evolving in front of your eyes here. However, if you look at the presence of bladder and bowel dysfunction, you notice that trumps even grade of reflux. Children with bladder and bowel dysfunction had a much higher incidence of infection than those that did not. in the American Academy guidelines, again, we recognized the importance of bladder and bowel dysfunction. And we came up with several recommendations and observations. We noted that when we did the meta-analysis, the literature review, that bladder and bowel dysfunction was associated with more infections on prophylactic antibiotics. It was associated with less reflux resolution if you followed patients conservatively for 2 years. And it was associated with a reduced success for endoscopic treatment, but not of open surgery. Not only that, if you succeeded endoscopically to correct reflux and the child continued to have bladder and bowel dysfunction, the recurrence rate, the reflux recurrence rate was much higher in that patient population. And the continued presence of bladder and bowel dysfunction after reflux correction was associated with an increased incidence of urinary tract infections. So you see clearly how important it is to correct bladder and bowel dysfunction before embarking on correcting reflux, because your success rate is going to be lower and your infection rates is going to be high after correcting reflux. The second factor that I would like to spend a few moments on is the effect of the foreskin. From 2004 to 2018, we followed 84 boys under 1 year of age who presented with infections that had primary reflux. 14 of those boys were circumcised and 70 were uncircumcised. This is relatively high by American standards, where almost 70% of the boys are circumcised. But that's we live in Southern California, where we have a larger Hispanic population that does not circumcise their children. These boys were followed prospectively for 2 years. And this is on the left here, you'll see the grading of phimosis that we used. And we looked at the infection rates based on grade of phimosis. The circumcised children and children with grade 1 and 2 phimosis, which means the glands can be exposed and cleansed, had no infections. Children with grades 3, 4, and 5 phimosis had all the infections. Now, when our policy was to every child that shows up with infection and phimosis, we give them a course of treatment with the steroid cream and retraction. And if they fail that, we recommend the circumcision. And the outcome of that study, when we followed these children prospectively over the 2 years, is that the boys that were under a year of age who received medical treatment for their phimosis and it responded well, they had similar, we downgraded their infection rates similar to that of the circumcised population. So correcting them to grade 1 or 2 phimosis reduces their infection rates quite significantly. And it's something simple that can be done. And if you wish to talk about how we recommend using the steroid, because we recommend really a very diligent routine of stretching for the foreskin without ripping. We can talk about that later. The other factor that we talked about is the grade of reflux. And we said that grades 3, 4, and 5 put the child at a higher risk for recurrent infections. Sometimes grading reflux becomes subjective, and there's always lack of agreement between some inter-observer agreement about the grades of reflux. And to avoid that, Chris Cooper from Iowa came up with a very interesting idea, and that is called the urethral diameter ratio. He takes measurements of the ureter in the widest part in the false pelvis, the widest part of the ureter, and he measures the distance between L1 and L3, the bottom of L1 and the top of L3, and uses that as a ratio, the ratio of the width of the ureter to the length of the L2 vertebra. And what he's demonstrated is that ratio is very reliable in determining and predicting who's going to develop urinary tract infections, and is also very reliable in determining who is going to have their reflux resolve. So instead of relying on a subjective measure, which is the grade of reflux, that urethral diameter ratio is something that I would encourage you to take a look at as a substitute for reflux grade. So we put all those factors together when Guy Haidas was the fellow in Toronto. We put all those factors together, in California, and came up with a predictor for the risk of breakthrough urinary tract infections in children with primary reflux. And the purpose was to really redefine the role of prophylactic antibiotics in these children. Identify the patient at high risk for recurrent infections who would benefit from prophylaxis and reflux correction. And this table here is very similar to the bubble chart that I had shown you earlier, but it lists the risk factors, the 7 risk factors, and it lists their milder to more severe, and it's a scale that goes from left to right. We looked at 303 children with primary reflux. 151 of them had completed at least 2 years of follow-up, and the median age at diagnosis was 9 months. 75% of them, again, were females, and the distribution of grade was your standard distribution of back then. Now our distribution of grade, as I'll show you later, is very different than this. But these are children that were, the study is almost now 10 years out. 84% of the children are presented after a febrile illness, and 64% of them did not have a bladder and bowel dysfunction. We are very, very, it's one of our nurses are very good at working with the children to correct bladder and bowel dysfunction in our population. And based on the results of this study, we split the patients into the low risk category, which are the children with grades 1 to 3 reflux without bladder and bowel dysfunction and the circumcised male. This was about 2/3 of the patient population, and their breakthrough infection rate was 8%, very low. So 2/3 of the patients with reflux that present bread and butter reflux really have very low rates of infections. The intermediate risk groups were the children with grades 1 to 3 reflux and bladder and bowel dysfunction, the uncircumcised male that has reflux and is diagnosed with an infection that bumps that up a bit. The females that were diagnosed after prenatal hydro with grades 4 and 5 reflux. So these are children that never had an infection. That was 1/4 of the population and had a 25% or 27% infection rate. The high-risk population are the grades 4 and 5 that presented after an infection. And that's only 6% of the population, but their infection rates were 62%. You see the big difference between the low risk and the high risk? 8% versus 62% infection rate. So based on this, we manage children with low risk with nothing. We don't put them on antibiotics. We obtain periodic renal bladder ultrasounds, bring them in and discuss bladder and bowel dysfunction, make sure that they're still clear, they're not constipated, they're drinking, they're voiding at regular intervals so that they don't get into trouble. So it's all preventative. The intermediate risk group, we put them on prophylaxis. We do periodic renal bladder ultrasound. We work hard on correcting their bladder and bowel dysfunction. And once that BBD is corrected, they shift into the low risk population and their antibiotics are stopped. And then the high risk group, we start them on antibiotics. Obviously, try to wait until they're about a year of age and then correct their reflux. We don't want to wait because we know 62% of them will have more infections, so there's no point in waiting. So based on this risk classification, we said, let's take a look at the RIVUR trial data to see if we classified the patients from the RIVUR trial to low risk and high risk, whether we could come up with a group there that benefited from prophylactic antibiotics and a group that didn't. So we went to the NIH. We had to write a proposal. It took a year to get the raw data, but eventually we got spreadsheet after spreadsheet with every visit that these children had and all the demographics and outcomes of the study, all the raw data. And Just as a reminder, the conclusion of the RIVUR trial was that the risk for UTI recurrence was reduced by 50% in the children on CAP. However, the absolute reduction was only 12% from 25 to 13. And the number needed to treat, remember this one, please, was 8. And so in my mind, this was, the clinical significance of that was, not so impressive. So when Peter Wang was the fellow with me in 2015, we got these data, and he spent a big chunk of his research year analyzing the raw data. And we used the same risk classifications, the modifiers in the females, circumcision status, higher grades of reflux, bladder and bowel dysfunction. But because the RIVUR trial included only very few patients with grade 4 and did not include any patients with grade 5, there really was no intermediate group there. We melted the intermediate group with the high group and created 2 categories, low risk and high risk. The low risk group was the circumcised males with grades 1 to 3 and no BBD, or the females with grades 1 to 3 and no BBD. And the high risk group were the uncircumcised males with grades 1 to 3, whether they had BBD or not, the females with BBD, or anyone with grade 4, and there were no 5s in that study, whether they had BBD or not. Now let's look at if we take the patient population and split it this way, you'll find that in the placebo arm, 2/3 of the patients were in the low risk group, 191 patients, versus in the high risk group, there were 110. So it's 2/3 of them versus 1/3. Similarly, in the prophylaxis arm, they split exactly the same, 194 and 107. The rest of the demographics were identical between the 2 groups. Let's carefully look at the results. So in the low risk population, children on prophylaxis had an infection rate of 19%, on placebo, and on prophylaxis had 14%. Number needed to treat goes up to 20, and there's no difference between the 2 groups. You could argue that the study was not powered enough to find the difference in the low risk group. However, how many times are we going to have more than 600 patients in a reflux study studied prospectively and in a randomized placebo-controlled fashion? I doubt that we'll ever repeat that study. And if we can't find clinical significance in 600 patients, is it really statistical significance over 600 patients? Is it really clinically significant? In the high-risk group, on the other hand, the placebo had a 31% infection rate, and the prophylaxis group had only 11% infection rate. So clearly, antibiotic prophylaxis makes a difference in the high-risk population. The number needed to treat drops to 5, and this is statistically significant. The Kaplan-Meier curve tells exactly the same story. In the low-risk group, you can see the 2 curves are parallel to each other, and there's really no difference at the end of the study. Whereas in the high-risk group, you can see there's a widening gap as the study progresses. So based on this, we now have modified our risk stratification, and I'm happy to share this with anybody who wants a copy of it. This hangs in my office and in my clinic, and my fellows and residents practice based on this. For female patients with reflux, we start with their grade. Females with grades 1 to 3, if they don't have bladder and bowel dysfunction, they're low risk. If they have bladder and bowel dysfunction, they're in the intermediate risk until this is corrected, and then they fall back to the low risk. If they're in the low risk and they develop a UTI, low risk does not receive prophylaxis, they are put on prophylaxis and are upgraded to intermediate risk. Children with grades 4 and 5 reflux who presented after prenatal ultrasounds and never had a UTI are placed in the intermediate risk and are put on prophylactic antibiotics. If they presented after a febrile illness, they're in the high-risk group, they're put on antibiotics, and their reflux is corrected as soon as they are over a year of age. Intermediate risk group, if they have a breakthrough infection on antibiotics, they are upgraded to high risk and they have the reflux corrected either endoscopically or surgically. For the males, the differentiator is age and circumcision status. If they're more than 12 months of age and or circumcised without bladder and bowel dysfunction, they're in the low risk group. If they have bladder and bowel dysfunction, they're in the intermediate risk group. And again, they get upgraded if they have a UTI. If they're less than 12 months of age and not circumcised, they're automatically in the intermediate risk group. If they present with a sepsis and a grade 5 reflux, especially bilateral, they're in the high risk group, and our tolerance for that is very low. In the past 5 years, we've been prospectively following 271 reflux patients based on this scheme. 58 of these children had infections. Now, we created this heat bar based on these infections, and you can see here the odds ratios. For example, if you had 2+ UTIs versus if you were under 6 months of age, female sex, high-grade reflux, under 6 months of age at the first visit, and grades 4 and 5 phimosis. And you can see as we go to the right, the odds ratio for infection increase. And this was not adjusted for whether they received antibiotic or not. For the children under 1 year of age, the heat bar is a little bit different. You can see that high-grade reflux, females, and then those under 6 months of age and the uncircumcised males, again, you progress from left to right with increasing odds ratios. 182 of the 270 patients were in the under 1 year of age, and these had 42 infections. Remember, I said that the distribution of grades is different today in the last 5 years than it was before, and that's because we're not getting VCUGs after the first infection. The number of early VCUGs are not happening, so we're only diagnosing children on the higher end of the spectrum of reflux. So when we looked at our all the children that we have been following for the past 5 years prospectively, there were 38 children in the low risk category. They had an 11% infection rate. In the intermediate risk, 23% infection rate. And these are children on antibiotics. And in the high risk category, 52% infection rate on prophylactic antibiotics. The low risk was not on antibiotics. So when Peter Wang was writing the RIVUR trial paper, he ran across this paper in the International Journal of Epidemiology, and the title was intriguing: Using Group Data to Treat Individuals, Understanding Heterogeneous Treatment Effects in the Age of Precision Medicine and Patient-Centered Evidence. And if you look at the picture, this picture is from that article in the Journal of International Journal of Epidemiology. And the face in the middle is a compilation or is a morphosis of the 10 faces in the periphery. So as that patient in the middle, does that face in the middle, which is that compilation of all the faces amalgamated together, represent the average? Does that represent any of these individuals? And it's an intriguing concept when you think about it, especially in view of the results, the American Academy guidelines and the results of the RIVUR trial were black and white. As clinicians, determining the best treatment for an individual, which is your task as a clinician, is fundamentally different from determining the average effect of treatment in a population, which is the purpose of a trial, of a clinical trial. It looks at the average means and standard deviations. So our job as clinicians is to understand how studies can be designed, analyzed, and interpreted to better inform individualized clinical decisions. Not just take the result of the study and say, yes, antibiotic prophylaxis works, or no, antibiotic prophylaxis doesn't work, and just apply it to every child in our practice. Your job as a clinician is to find the subtleties, the little nuances that says this particular patient would benefit from this particular treatment, regardless of what a clinical trial, the means and standard deviations of a clinical trial says. So I'll leave you with some take-home messages. Number one, treat reflux as a spectrum. Don't treat it as whether the child has reflux or not. Individualize your investigations and management based on the child's, where that child falls in the spectrum of reflux. Prophylactic antibiotics is beneficial for about 1/3 of the patients with reflux. 2/3 of the patients with reflux just need their bladder and bowel dysfunction managed well, their foreskin managed well, their water intake, their voiding frequency, etc. Managing bladder and bowel dysfunction and prepuce is probably more important than putting people on antibiotics. You can put them on antibiotics until you get a handle on their BBD and their foreskin opens up. But once that's done, you don't need to expose them to continued antibiotic prophylaxis. I don't do routine follow-up VCUGs as I'm following children with reflux. I'll only do them if the child has an infection under observation, and if I'm contemplating correcting the reflux and I'd like to know if it's still there or not, and what grade it is, and what laterality it is, so I can plan my surgery. But routine VCUGs every year or two in this patient population exposes them to the trauma of catheterization and radiation, which is totally unnecessary. I really appreciate your attention, and I'm very happy to maybe have a discussion and try and answer some questions after this. I'll stop sharing my screen.
Thank you very much, Professor Puri, for your very excellent presentation and the very useful talk regarding the reflux. We have learned a lot from your published work. Over time, we changed even in our practice, and you will see in our interactions. So this is a time for interactions, and before our experts come in, I would like to share my screen, and I will be raising a couple of questions to you. Hopefully, you receive this presentation, and I hope this will work. So once again, thank you very much, Professor Puri. And this is the protocol we try to follow. At least I try to follow in my practice. The purpose is the reduce number of VCUG and improve the detection of high-risk VUR. We believe that the risk stratification is the most uncontroversial aspect of the vascular reflux. So after the first or second febrile urinary tract infection in a male or female child, up to 1 year of age, we perform VCUG, use USG, and even if it is normal, if child develop a second urinary tract infection, febrile UTI, we do VCUG, and then if required, later on we do DMSA, that is bottom up sort of thing. And in an age group of 1 to 5, we do ultrasonography with a febrile UTI or DMSA scan, acute phase DMSA scan. And if there is a lesions seen in the DMSA scan, then only we do voiding cystoscopy. And in above 5 years of age, the risk is less. USG only, and if sonography shows some changes in these patients with febrile UTI, we do some other investigations. So you agree with this, sir? Does it work really in the practice?
So let's think about this for a second. First of all, a lot depends on the quality of the ultrasound, right? Even in California, where medical care is quite advanced in many centers, there are children sometimes come to me with ultrasounds that are so grainy and so, they come from, private practice type centers where the machines are not up to date. High resolution ultrasound today provides us with images that in many times I don't need to get a DMSA scan. I'm so happy with the quality of the ultrasound when I see the perfect contour for the kidney with great echogenicity that I do not get I rarely get a DMSA scan if I have a normal ultrasound. And we looked at that many years ago. We looked at over 100 children that had both a DMSA and ultrasound, and the difference really was only 4% in meaningful scars that DMSA picked up that the ultrasound didn't pick up. The DMSA is an expensive test.
Perfect.
And it exposes children to a reasonable amount of radiation because, as you know, the DMSA is given, the tracer is given, and then you have to wait 4 hours for the concentration in the renal cortex to happen, and then the imaging occurs. So it's a longish test. It takes about 4 hours. It's expensive, at least in North America, it is expensive. And sometimes DMSA is not readily available. I don't know how readily available, if you've had the same shortage we've had in North America or not. But
perfectly, sir. We took your message and we are working on that. We are trying to standardize our sonography. And for that, what we are doing is that we are picking up 1 or 2 good sonologists, and we try to feed all of our pediatric patients to them. So they also become expert into that. And we try to get, ask them not to just write down the report. We try to get all pictures,
yes,
like the echogenicity, cortex quality, then the glacial pictures, pelvis, ureter, bladder, full bladder level sonography to see the ureteric dilatation, posterior bladder. So after we complete all pictures, then only we believe. So we are trying to standardize. And you are right, sir. Most of the time in our discussion, the argument is that how to rely on the sonologist. So what we trying in our centers that we identify 1 or 2 sonologists who are ready to do dedicated pediatric urology. In India, advantage of sonography is that it is very much available. It is very less costly. And as you know, it is non-traumatic, no radiations. So advantage in India, suppose if I decide to send any patients for sonography, I get the report within 1 or 1.5 hours. So we are trying to exploit that advantage. But only thing is that we have to agree that we have to standardize the sonography reporting for this purpose.
I think if you have good ultrasound, you're fine. If you don't, then the DMSA is a very reasonable choice here if it's not too expensive for your patients.
Okay. So now coming to the second issue is that I agree that there are a lot of controversy for the continuous antibiotic prophylaxis or intermittent prophylaxis or no prophylaxis. But in country like India, what we are seeing is that we must not pass the onus of preventing morbidity of febrile UTI recurrence and potential injury to parents because of the challenges associated with the clinical presentation and diagnosis of urinary tract infection in infants and young children, especially in developing or underdeveloping country. You agree with this statement? And that way we probably be different from the developed countries.
And even in India, I mean, if you have a family that's well educated, that understands the principles versus a poorer family from a faraway village that's not under your control, right? So if you have a family that's very well educated, that understands the concept and the importance of correcting phimosis and correcting bladder and bowel dysfunction, sure, you work with them on that premise. If you have a poorer family that, you know, you don't even know whether they're going to be compliant with the antibiotics if you prescribe antibiotics for them, right? So family compliance with your instructions is one of our bigger challenges with this condition.
And the third issue is that regarding continuous antibiotic prophylaxis, and we heard you also, and we seen in the RIVUR study that it is a maximum benefit in patients with the BBD because that increases the risk. But sir, here I would like to ask a question: how exactly you recognize element of BBD in the less than 1 year of age, or those who are not toiletry?
Yeah, so it's in the under 1 year of age, it's mostly constipation. So you need to ask the family about the bowel habits of the baby. And if the child is having only, a baby is having only one bowel movement every 3 to 4 days, then that's an element of BBD. The other thing which is important for all of us to remember is to examine babies in diapers at every visit, looking for rashes. Take that diaper off and look for a rash. Look in between the labia and a female girl to see if there's stool smears in there. And educate the families on how to maintain proper perineal hygiene for these babies. Because E. coli, it's all coming from the colon and the rectum and the stool. So the more we pay attention to their cleanliness and to their perineal hygiene, the more successful we will be in preventing recurrent infections.
As you mentioned in your presentation, sir, we consider these two trials comparatively much convincing, and we feel that in country like India, when we see patients with the high risk, we generally try to put them patients on the continuous antibiotic prophylaxis. You agree, sir? Means your critical comment again here that because see, we all now know, we try to stratify the patients, and we generally try to avoid detecting even the low-grade reflux patient. See, we don't do now VCUG blanketly in all patients of antenatally picked up hydronephrosis. We generally keep them under the observation. We request the parents that if the child develops fever, go to the general practitioner, pediatricians, or come to my clinic with the sterile, this urine collected into the clean portal. We'll check the presence of infection, and then only we do subsequent investigations. Our maximum effort is to avoid detecting those patients with the low-grade reflux. So we generally now not picking up the low-grade reflux. We try to avoid the further investigations. So in those high-risk group of patients, we generally still believe that if we try to if we prevent the urinary tract infection, further episodes of peripheral UTI, they won't develop probably new scar. You agree with that, sir?
Yes. So if your population is skewed towards the higher risk now, which is most people will have a population that's skewed towards the higher risk, then this is the population that benefits from antibiotics. And if they have breakthrough infections and you've optimized them medically, then they're the population that benefits from surgical correction.
So you agree that, sir, we should not use terminology scar for any lesions seen in the DMS scan of VUR patients. Do you think that we need to codify these lesions? Reason that using the scar terminology, it is confirmatory of devastating effect of pyelonephritis. One. Second thing, it sets in the wrong treatment in few patients and creates fear in the mind of parents and caretakers and does not allow proper prognostication of the patients. So believing this thing, we try to differentiate these lesions into the congenital and acquired. In congenital, we don't have a history of febrile UTI, and we generally see global reduction of the kidney rather than any polar lesions. In a acute inflammation, we generally see this photopenic area without loss of contour, and those who have a recurrent history or delayed scan, and if we see loss of contour with this kind of reflux with the history of recurrent UTI, we try to classify and try to initiate the treatment accordingly. You agree that we need to really follow this kind of a codification or classification?
Right. So for the younger members of, the residents and the medical students in the audience, it's important to remember that the kidney grows like a tree. Embryology of the kidney starts from the bladder up, just like a tree grows from the ground up. The ureteric bud branches into the renal, the cells that will form the future kidney, nephrogenic mass. And this branching extends all the way to the collecting ducts. And then, so it's like the terminal branches of the tree are the ureter, and then the leaves are the canopy of the tree are the kidney, the nephrons. And so if I have a weak trunk, I'm not going to have a large canopy. If I have an abnormal ureteric bud, I'm not going to have a normal kidney. I'm going to have a smallish kidney that's globally smaller than the other side. If I have an acute inflammatory process, I have edema and inflammation. If I have pyelonephritis, I have edema in the kidney. The edema results in hypoperfused areas, and therefore the DMSA shows up like your middle picture here. And if you have chronic scars after that, acquired scars, then you'll have the polar lesions that are injured and scarred. And it's important to categorize parenchymal changes. I like to call them parenchymal changes rather than scars, unless I know I have a previous DMSA that's perfectly normal, and then the child had a couple of febrile UTIs, and then I have a DMSA that shows scars. But our job as clinicians is always to sort of look at, if you see abnormalities in the parenchyma, that patient is automatically in a higher risk because they've already injured their kidneys.
And those with the global changes, they are probably different reflux patients. I'm giving two cases. Both the cases, one is a 6-month child, another is a 3-year child. Only a 3-year child had a vague abdominal problem, no febrile UTIs or UTI, and they were grown very normally. And the VCUG were performed as a part of further evaluation, and they were having a high-grade hydronephrosis. So they reveal this high-grade reflux on unilateral, all male patients. And you see in the DMSA scan, there is a global reduction into the kidney. And there are no history of VTI. And here I have given another scenario where we can see VORD. Do you think that these are the patients, for example, this patient, though having a completely normal urethra, are they patients almost like those patients? And this could be, as you say, could be a reason of bud therapy, as well as the problem with the metanephrosis and dysplasia and hypoplasia, or it could be because of temporary intravesical obstruction in utero. You believe that they are completely different than those patients which we discuss.
Yes, for sure. They are very, the kidney that is developed in the face of obstruction is very different than the kidney that, I mean, they both of them may have ureteric abnormalities, urethral bud abnormalities, but the one that has a simple urethral bud abnormality without obstruction is a different kidney than the kidney that has obstruction and a urethral bud anomaly. Totally different.
And do you think we must treat them differently? How do you treat? Suppose these patients, this kind of a scenario present to you. We generally don't treat these patients with antibiotic prophylaxis. That I believe that they do not have any tissue, a healthy tissue to respond to the onslaught of infection which is coming because of high-grade reflux. So they are least likely to respond. And in that circumstances, there is no role of CAP. And secondly, upfront nephrectomy we do not perform. So what is your advice for this subset of patients? So which we are not that infrequently seeing in the country like India.
So we're not talking about the obstructed patient now, right? Just the primary reflux.
Yeah, this patient. For example, take this patient. This patient is of 6 months.
Yes.
And investigated, and we find out this much.
Yeah. So the fact that this patient is now functioning on one kidney and has reflux puts them in a slightly higher risk category for me, in my mind as a clinician. Their risk for infection may be low. However, if they knock off their other kidney with an infection, that's a problem. So I'm a bit more careful with these patients. And the other important factor in the second group of patients is that over time, when they hit their teenage years, there's a higher incidence of hypertension in them. And of course, you appreciate the consequence of hypertension on the normal kidney. I also like to follow them closely to make sure that the normal kidney is going to undergo compensatory hypertrophy.
Right.
To make sure that they're going to be okay as far as nephron mass and renal function wise during their adolescence and puberty years and beyond, of course.
So last, sir, things I'm giving that what is the exact role still of a diversion in a high-risk patients of less than 1 year? For example, I'm giving you a couple of incidences. This is 10-month child with a couple of febrile UTI, severe constipation. Another scenario, 2-year male child with recurrent febrile UTI, grossly hydronephrotic kidneys, massive reflux, and devastating effect in the DMS scan because of recurrent febrile UTI. Another scenario, again 6-month child with recurrent febrile UTI with massive reflux. So do you think these are the cases, how to manage these cases and some role of diversion? And if diversion is still there, which is your preferred diversion?
Yes, I think there is a role for diversion in the child that you're describing here that has recurrent infections with high-grade reflux, because in these children, your example showed a creatinine of already elevated at 0.7, and I think there's no reason to take a chance in these children if you can't get them to stop having infections. You're going to end up without kidneys. This is the situation where you're going to end up with renal failure. My preferred form of diversion for children with bilateral reflux like these is doing a loop cutaneous ureterostomy on one side, low loop cutaneous ureterostomy on one side. And the purpose of that is that it allows the bladder to continue to cycle. So I'll take the better side and I'll divert this side to protect it completely. And then the left, so in this case, the right kidney looks like the better kidney for me. And I'll do a right loop cutaneous ureterostomy and allow the left kidney to fill the bladder, cycle through it, and come out on the other side. The advantage of doing the loop cutaneous ureterostomy low is that the right ureter will then thin out. Instead of having this big dilated ureter, you'll have a more normal caliber ureter. And long-term, after the reimplant, that's very critical because the ureter is not a passive conduit, as you all know. The ureter is an active muscular conduit. It forms a process of peristalsis. So the peristaltic effect is by the ureter opening up, receiving a drop of urine, isolating that drop, milking it down, opening up, and then the walls coapting, isolating the drop and milking it down. If the ureter is very dilated, that coaptation cannot happen. If the ureter the walls cannot come together, it cannot milk the drop of urine down. So it becomes a passive conduit with each drop of urine being pushed from behind by the subsequent drop. And the pump here becomes the heart, really. Glomerular filtration is pumped in by the heart. So by doing the loop cutaneous ureterostomy, within a few months, that ureter will shrink down and become a very thin caliber again, instead of this big dilated bag. And the reimplant procedure will be much, much easier and much more straightforward. And hopefully you'll have better peristaltic activity in these ureters.
Thank you, sir. This is the end of face-to-face segment from me. And I'm now inviting Luis, Professor Ansari, and Dr. Rahul to take the interactions further. So Luis and Ansari, you can, as an expert, discuss a couple of things with Professor Puri.
Should I go first?
Professor Ansari?
Yes, please.
Yeah.
No, Dr.
Yeah,
Luis,
go
please go. Please go, Luis.
Yes. Okay, Dr. Khoury. So again, was a treat and a pleasure to listen to your talk. I think as Dr. Tavani, when he mentioned to me that he wanted to do something about legends in urology, so I think your name was at the top of the list, and it's not by mistake that you're the first one to open this series. And I think each time that we have an opportunity to see, watch one of your talks, especially on VUR, I think it's excellent. I think we have to really take advantage and savor it, because again, I'm on the other side of the country here, so I don't get to be exposed to your talks and your thinking process like we used to, like more than 10 years ago. So for me, it was really a treat to share that moment with you. So basically,
Thank you, Luis. Thank you for that. That's very kind of you.
No, but you know that I speak from the heart, and that's true. So now, again, for discussion, sometimes from what I learned from you, and again, you have to adapt, as I think you're very, very like nail on the head, even though we have guidelines or have like a randomized clinical trials. I think not only you have to adapt to the conclusions or the results of that study to your particular patient, but also to your setting. And sometimes, again, my setting at McMaster may be different from your setting at Orange County. So a question to you would be, do you think, when I was looking at, which is brilliant, that is Dr. Khoury written all over, like, those two flow charts, one for the female patient and one for the male. Do you think in the male patient, if I'm trying to simplify things, for a resident or for people to be able to do in the community, because in my practice, I work a lot with family physicians and primary care providers and pediatricians. And sometimes I may not see that patient until later on, because they will, again, I know about your paper about, doing the steroid cream or trying to gently stretch the foreskin. But do you think it would be reasonable if I knock the effect out of the foreskin, then that algorithm for the male patient would be very simple, because it would be basically, I would have a male child with high-grade VUR, because most babies with reflux, the male ones, they have a bilateral high-grade and a congenital abnormality of the kidney. So if they are circumcised, I'll be able to reduce the risk and then only rely if they're constipated or not, because this has reflected when I think we're in Cincinnati once, and I think we discussed about, and I look at my data, and one out of 10 patients that I underwent reimplantation were males. And then I went to look why, and probably because different from your series, I was circumcising them according to those meta-analyses saying that the circumcision would reduce that risk of infection. So I'd like to hear your comments on that, and if it's reasonable. And then I'll pass the stage to Dr. Ansari.
Yeah, I mean, no question. You saw on our male flow chart, instead of grade came second to foreskin and BBD. And if you take foreskin out of the equation, then you're left with BBD. There was a question on the chat: how do we manage BBD in our center? And it's very simple. It's 4 simple things that if you get your families to instruct the children and maintain them. Number 1, a cup of water for every year of age. So a 6-year-old needs to drink 6 8-ounce cups of water per day. An 8-year-old, 8 cups, and every adult 8 cups. So 2 liters of water per day. Void every 2 to 3 hours. You need 7 urinations per day. Every child should pee 7 times per day. If they do that, the doubling time, E. coli doubles in the bladder every 20 to 30 minutes, as you know. If a child holds for 6 to 8 hours, it's too many doubling times. The number overwhelms the bladder defense mechanisms, and you end up with an infection. So frequent voiding. Number 3, perineal hygiene. We talked a little bit about that in the babies in diapers. In older children, it's not enough to dry wipe and have girls wipe from back to front. It's better to wash. On Amazon here, you can get a little water nozzle that fits under the toilet seat so that the children can wash their bum after every time they poop. And it's like $30 for that little bidet that fits. And it takes literally 10 minutes to install. So good perineal hygiene. And then 4th, fiber, and if that alone doesn't work, some PEG or Miralax or whatever it's called in India. But you need something to improve the quality of the stool. We always want to think of constipation as the quality of the stool, the motility, and the hydration status, because hydration determines the quality of the stool. If the child is dehydrated, the colon will suck every drop of water from that stool to conserve water. So giving something like PEG, if the child is not drinking water or is relatively dry, won't work. So these are
Professor
common
Ansari.
sense ways of preventing infections, and they work very, very effectively, frankly, better than any antibiotic.
Yeah. Professor Ansari.
Yes, in continuation to the same BBD, because we find whether this is a Swedish trial or RIVUR trial, and BBD is one of the most important influencing factor in the management of vesico-ureteric reflux. If we see the RIVUR trial, surprisingly, the median age of most of the subjects was only 12 months, and the prevalence of BBD was nearly 60%. Even in Swedish trial, it was greater than 30%. Is that we are diagnosing BBD early in the Western population, while in Indian population, we have hardly a 30% prevalence of BBD in children with reflux. So what are your thoughts?
It may be diet related. I mean, the Western diet is horrific. And I don't know if you have McDonald's in India or not.
Plenty.
There you go. Wait until your children become obese. I mean, more than 35% of the children I see in my practice are overweight.
Yes.
It's ridiculous. They eat so much carbohydrate and so little fiber. No wonder they're constipated. The American diet is a horrific diet. I spent more time in my office talking to families about diet and limiting carbs to 200 grams per day than I spent talking about urology. So, when you see a 3-year-old that weighs 90 pounds or 42, 43 kilos, that's 2 or 3 times what they should be weighing. I don't know how well children drink in India, but children in America don't drink. They just don't drink water. They don't like the taste. Do you have the same struggles in India? Do your children drink water or not?
The children usually do not drink. They have a tendency worldwide not to drink water, because unless the mother asks them or tempt them to drink some water, then only. Otherwise, it's not just like an adolescent or a grown-up child who feels thirsty and go for the water. The problem here is also the same. But I feel that what you have said, the diet may be one important factor affecting the prevalence of this.
For sure.
And secondly, yes, and secondly, I just wondering, in RIVUR trial also, the prevalence of BBD was much higher. Almost all kids, female kids, they were diagnosed with BBD. If you see, more than 90% of the children who were diagnosed with BBD, more than 90% they were females. Why this is a racial decision from the nature, even if it is a dietary region?
Well, I think it's just a reflection of, so the RIVUR trial, most of the boys that were in the trial were circumcised. And the majority of the girls that came into the trial, because girls tend to have, they're more likely to have urinary tract infections compared to circumcised males. The percentage of girls that have infections with low-grade reflux are mostly the children with BBD. I mean, you rarely have infections if you don't have BBD. Reflux is just a secondary finding, right? I mean, if you look at all the children that come into your practice with that you see for recurrent UTIs, and you do a VCUG and they don't have reflux, when you ask the family about their water drinking habits, their voiding frequency, their bowel habits, you'll find that the majority of them have some element of bladder and bowel dysfunction.
Luis.
So,
Yes.
Rahul, do you have a couple of questions? One question from Malik. I think, Malik, you can directly ask the question.
We have
Yeah.
a few questions.
Thank you.
Let me just
Professor
go
Kaurik. I was just wondering, when you said the diet and all, India is actually mirroring US. What happens in US 5 years back happens here in India now. All the diet and every pattern comes through. But I was just wondering, one of the questions which was always in my mind was, there was a lot of discussion when we were operating. A few of our professors used to say that you do only tailoring of that part which you want to reimplant, and few of the others would say that you need to tailor a full length of ureter because it needs to coapt to get the appropriate propagation of the bolus into the bladder. So where are we at this? Because if you have to do a long tailoring, you end up doing a huge dissection. You'll have to go peritoneal and then do it. So where do we stand on that particular issue?
Yeah, so I do very little tailoring, to be honest with you. I try to wait if I have very dilated ureters, and I'll do a loop cutaneous ureterostomy and wait it out a bit. If I have very dilated ureters and the child is not having infections, I'll wait until they're older. Because if you wait long enough, as the child gets taller and longer, those ureters will, I mean, that's the beauty of growth. So I would say if your child is having infections and has big dilated ureters, do a loop cutaneous ureterostomy if it's a bilateral condition, and let those ureters settle down. If the child is not having infections and they have high-grade reflux but are managing well without infection, wait. Make sure they have good emptying habits so that they don't increase the distension of the ureters by being holders, because those children with high grades of reflux tend to be holders and can go hours and hours without urination. But if you wait them out and they empty frequently, you'll be very happy with how those ureters thin out and tailor themselves without you having to do anything for them. And if you end up doing a reimplant in that situation later on, let's say at age 4 or 5, if you manage to get them through 4 or 5 years of growth and elongation in their height, you might want to, if the ureter is still a bit dilated, I do a shorter tunnel and I'll do a half rosebud, like a cuffed anastomosis at the bottom end, to not leave them with a very gaping ureteric orifice. And that does a good job preventing reflux without increasing the resistance. If you do a very long tunnel, you increase the resistance in front of that ureter, so that that ureter has to work hard to deliver. And if the peristalsis is not perfect, then that ureter will blow up on you again.
Rahul, you can go ahead with
Corey,
the
just to follow up on this. Anil, 1 second. Why are we not looking at the vesicostomy versus the ureterostomy? Because even in vesicostomy, there is cycling of the bladder. But probably the pressures on the bladder, on both the ureters, would be probably much, much lesser when we do a vesicostomy. And the bladder is easier organ basically to reconstruct rather than the ureter to reconstruct.
Very true. I can't argue with you. A vesicostomy is a very reasonable option. It all depends on what you're more comfortable with. I just found that with the ureterostomy, the ureters vanish completely for me. They thin out beautifully, and they cycle the bladder a bit more effectively. I don't know if you've ever tried to reimplant a dilated ureter after a vesicostomy. I find that the mucosa doesn't elevate as well to create the tunnel as a bladder that's closed, not exposed to the outside, and cycles more effectively than just, I know a vesicostomy, you get some urine in the bladder, but it's not as effective as when the bladder is closed. When you disrupt the musculature of the bladder and you create a stoma in it and you elongate it, and you go back and try and do a reimplant with a dilated ureter, you'll notice the difference over the years. I mean, I've only started doing loop cutaneous ureterostomies in the last 14, 15 years. Before that, I was doing exactly what you're describing, a vesicostomy. And in my anecdotal experience, the reimplant procedure is much, much easier in the group that had a loop cutaneous ureter, a low loop. You don't want to do a high loop so that you don't compromise the length of ureter, because I throw out the distal ureter when I do the reimplant. I find that creating the tunnel is very much easier when I haven't had a vesicostomy.
So quick question by Rahul from the chat box.
The
And
first,
we have a few international guests, Professor Sirjil from the Pakistan, Professor Samim from the Bangladesh. If we have a couple of minutes after your question, if they have some question, they can directly ask. So take quickly 2 or 3 questions
Sir,
from the chat box. Rahul, go ahead.
thanks very much. Sir, the first question which was asked was, how much time it takes for a pyelonephritic scar to develop, and is it different in a different age group after a urinary infection?
You can see scars in a very short period. I just saw a patient of mine with a neurogenic bladder that I had done an augment. He's a teenager, and he had 2 normal kidneys on an ultrasound in 2018. And in 2019, his kidneys were okay on the ultrasound. I hadn't seen any changes. I saw him back in 2021 with 1 kidney shot completely. And he had 1 or 2 febrile illnesses. But being an adolescent and a teenager, he wasn't irrigating his bladder. He wasn't clearing mucus. He wasn't catheterizing regularly. And he lost 1 kidney. It's down to about 23% function. So, and that's in a fully, this premise that you don't scar adult kidneys. This is an 18-year-old boy. When he lost the kidney, I augmented him at age 15.
I think Dr. Sivam want to ask directly question. Dr. Sivam, unmute yourself. Unmute yourself, sir. No. Sivam, I think you won't be able to unmute yourself.
Yeah. Okay, sir, I'll do one thing.
Yes.
I'll only ask
You go ahead with the question.
Yeah, I'm able to unmute now.
Okay. Perfect. Go ahead quickly.
Thank you. So thank you, Dr. Tony. It was wonderful listening to you. It was really enlightening. And my question is, when you talk about circumcision or non-circumcision, the point is, as you have already said, that phimosis is important, not whether it is circumcised or uncircumcised. So should we put phimosis, the high-grade phimosis, as a criteria, not circumcision or non-circumcision?
Yes, I agree. It's the foreskin status that matters. If you have foreskin that retracts and the child is retracting and performing good preputial hygiene, pulling the skin. When you ask the boys in your practice how often they pull their foreskin back before they urinate, it's a minority that does. The parents, even when the adult men, they say, do we have to do that? The adult men aren't aware that they need to pull their prepuce back before they pee. They shouldn't pee on the skin and inflame the skin. So it's an education that we have to provide for our patients.
That's true. That's true. Another question is about the infections with a lot of antibiotics. We know that human microbiome is coming up in a big way, and which is probably dysbiosis, which results because of them a lot of antibiotics, antibiotic resistance, and the diet also plays a big role here. So would you think that is again a very big factor in having recurrent urinary tract infections?
Yes, for sure. Not only that, I think it determines what bacteria you end up having in your stool. And as you know, especially in girls, the type of bacteria in the stool determines the bacteria that's causing their urinary tract infection. So that is going to be a very critical issue to answer. A lot of our families are starting their children on probiotics when they're taking, especially those on prophylactic antibiotics, they take probiotics. And it's important to remember, if you're prescribing the prophylactic antibiotics to be taken at bedtime, which is a good time to prescribe it so that it sits in the bladder, because most of the antibiotics we use for prophylaxis are excreted in the urine in one pass and they don't get reabsorbed. So they sit in the bladder all night, sterilizing the urine. And so you don't want to give the probiotic with their evening meal. It's better to give the probiotic then with their morning meal This way, the probiotics work away from the antibiotics and they don't contradict each other.
So till we try to unmute Dr. Sergil from the Pakistan, go ahead, Rahul, with another question from the chat box and try unmute Dr. Sheila.
Yeah, okay.
Dr.
Sir,
Sergil.
there is one question which is saying, what is the role of direct radionuclide cystogram, and can it replace the VCUG in a follow-up?
So direct nuclear cystograms are very sensitive in detecting grade 2 and higher reflux. Their downside is that, and the nice thing about them is that, there's no confusion when there's constipation and gas and a fine ureter. It's very simple to see, and it's very easy to see grades 2 to 5 reflux. There's a couple of downsides to them. One is that you can't detect grade 1 reflux because it gets covered by the bladder, and you won't be able to see it. It's not definition-wise, it's not as good as a X-ray cystogram. And next is you can't grade reflux on it. It only tells you if there is reflux or there isn't reflux. It's okay to use for follow-up, but after the first infection, when anatomical detail really determines how you're going to manage the child, it's important to get a radiological cystogram, because then you can look at the bladder. You can look if there's filling defects such as a urethrocoel, if there's trabeculation, the shape of the bladder, if there's a diverticulum or not. You can grade reflux appropriately. You'll detect contralateral. If you have grade 1 on one and higher grade on the other, you'll be able to pick it up. So the first VCUG should be a radiological one. If you are inclined to get follow-up studies after that, you can get a nuclear cystogram.
So last question, and then what of things by you, Rahul. So please, Luis, you want to make a small comment?
Yeah, a quick comment. Just so Dr. Khoury has been bombarded with questions. But just a quick one. So I think I learned from him, but I think from now on, I have been doing only one VCUG for patients with VUR. And I think I'll explain why. I think I learned from him. He always used to tell us that you have to, you don't need to keep trying to find the patients or try to be anxious to operate. You just have to wait. As long as you follow the patients closely, you have to wait for them to declare themselves. So I usually, based on what he said, we also have, we don't do VCUGs for all patients with prenatal hydronephrosis, no more like, isolated high grade, is bladder abnormalities, like, dilated ureters. But once I do that first VCUG, one of our studies, we try to stop the prophylaxis after 12 months, between 12 and 15 months, as he showed, the risk of infection is higher in the first year of life, especially in the first 6 months. And then if the patients present with infection after discontinuation of antibiotics, then we have the open discussion with the family, but I think at that point, the patient has declared themselves, and we either go for a surgery or endoscopic injection. And just to one note, for those patients who present with infection after discontinuation of CAP, 85%, like he showed, were girls with high-grade VUR and that they had BBD. So of those patients, less than 10% were boys. So that's why I think if you stratify the way he showed, I think you can only do one VCUG, you minimize the radiation. I also don't do a lot of renal scans because I think unless for research purpose, I think mainly what's going to drive the management will be the way the patient presents, the morbidity and the risk stratification, what you're dealing with. So I think these are my final comments.
So before we end, I would like to thank my international friends, those who have joined from Pakistan, Bangladesh. Dr. Sergil has joined from the Pakistan. Dr. Sameem Istiaq is joined from the Bangladesh. A couple of friends joined from the USA, from the Saudi Arabia, from the Turkey. So we have a good number of friends joined from across the globe. Thank you very much for joining this event. And before I hand over Rahul for vote of thanks, Dr. Kuri, we would like to have a small comment from you for this session.
Well, I think it's, I really enjoyed my time with you. I think this is an outstanding educational experience for all of us. I would encourage you to continue this, and you know, you will have many of the North American and European urologists that are more than happy to participate in this program. Going forward, I would like to propose that once we have this platform for the intraoperative cameras that transmit directly, that we have a session similar to this for open surgery with discussion during surgery, because I think workshops like this, whether you're doing reimplants or hypospadias or bladder augment, bladder neck reconstruction, exstrophy closure, you name it. I think doing it in and having more and more people benefit and discussing, everyone improves eventually.
Thank you very much, sir.
So I will,
so Rahul,
once that technology is more available, I will touch base with you, Anil, and we'll organize something through either the School of Urology or through your society and get something organized.
Anil, just give me half a second, just half a minute. The thing which I would like to say is we pay respects to two great pediatric urologists who left us and then they become stars in the sky. Dr. Alan Rettig and then Hardy Hendren. Two great people who changed the pediatric urology. So from the USI and ISU and all of us, we pay our respects to them. And then I reiterate that we are all indebted to them for their great contributions to this particular specialty. Thank you for this time, Anil.
Yes, for sure. For sure. Well said.
Rahul, what of things?
Thanks very much, Dr. Anthony Curie, for accepting the invitation. Because of you, the thought which we had to start the focused and specific sessions on pediatric urology, nothing better than this to start with you, reading a chapter in a Campbell and then listening to you, you know, it is such a good feeling. I would like to thank the Urology Society of India and ISU for accepting our thought and making it possible. I would like to appreciate the efforts of Dr. Anil Takwani sir and the team, and specific thanks to Dr. Luis Braga sir for making this possible. And I would also like to thank all the attendees who made this program possible. Thanks very much.
Thank you all. Have a great day.
Dr. Chawla, with your permission, can we call it today? Dr. Chawla, you are there? Okay, fine. So let me take this opportunity and thank you once again, Professor Puri. Thank you, Luis. Thank you, Ansari sir. And all my friends, those who joined from the India and across the globe. We'll see you very soon in another interaction with the Legion. And Professor Puri, we are having another program, which is we meet with the global friends with our global pediatric urology meet under the aegis of Urological Society of India. Generally, we keep it in the month of November. And this time, if possible, we'll send you the invitation. We will send you the invitation if possible. We'd like to have your participation into that. So, thank you.
Sure.
So thank you once again, everyone. Yeah.
Yes. Thank you all, and have a great day.
And goodbye.
Thank you.
Thank you.
And have a nice Sunday to all of you.
Yeah.
Goodbye. Thank you.
Bye.
Thanks very much.